So basically, as I said, this definition, because obviously it's different to have a 1 kilo baby than a 5 kilo baby with a giant omphalocele. That's why the difference in terms of how to define this complex condition. And also these giant omphalocele represent not only a huge challenge for surgeons, but also for the NICU people, because these patients are difficult to manage. Okay, and this is a real stuff. These are 800 grams baby and a 3.2 kilograms, and the 3,200 grams baby. So it's obviously this a different size, but the problem is exactly the same. We have a giant omphalocele, and usually giant omphalocele meaning that you cannot do one surgery and just solve the problem and get everything, the bowel and the liver inside the abdomen, because obviously it doesn't work like that. And you need to deal with this patient usually for a long time, and it's very difficult to basically treat these patients. So there's been a lot of strategies for dealing with that, but there's no standard of care anywhere. There's no that universal protocol to deal with these patients. And basically the two ways to deal over the world has been, or you manage with a surgical silo, or you do a medical conservative treatment, and we're going to talk about this a little bit. The surgical silo basically is take the patient to the OR, remove the amniotic sac, and you stitch a silo, and the different ways to put a surgical silo, meaning it could be a proline mesh, could be a blood bag, a lot of, or even a preformed silo. But basically the problem is that the extension of the abdominal exposure. So basically you have opened the abdomen to the, to the environment, and exposing all the liver and the bowel to, within all the problems. Usually they require multiple surgeries, obviously multiple anesthesias. And the problem with these surgical silos that in the midterm or long term, they can get infected, they can detach and require a new surgery, or they can, tear, and you need to readdress and redo the surgery with a new mesh or bag. So it's not a perfect solution, and have a multiple problems in the midterm with these patients. On the other hand, the medical treatment, meaning what is called the pain and wait, where you do things over the amniotic sac to make it, a scar, and then the skin take over, and basically the patient end with a huge ventral abdominal hernia that you need to deal with that within 1 or 2 years after. And obviously it's a long way to deal with that. Sometimes you can get toxicity or infection because of this scarring, and actually the treatment at the end is not perfect, and they suffer for a long time with this huge ventral hernia within the first years of life. So we start with about maybe 12 or 15 years ago with a new approach of this problem. And this is something that was done the first time in adults in some kind of another problems. And one surgeon from Colombia, actually called Cristóbal Abelo, invented or started with this treatment, what is called a non-surgical silo management. And what is this? Basically, what you do is you made a silo without touching the amniotic sac at all, even with patients that have a disrupted amniotic sac that you can repair with suture, you can put this on top. So basically you use this, what is called the duoderm, that is actually a hydrocolloid dressing, to achieve the reduction of the omphalocele in stages. And usually we'll talk about this in the future. In 95% of the cases, within 2 weeks, you can achieve that. But basically, the first thing that you don't do any surgeries, you can put this duoderm on top of the omphalocele, at the NICU with any other surgical procedure, and you stage the closure depending how the patient is doing. So the most important thing that you don't remove the amniotic sac at all, and those patients are basically managed in the NICU with a protocol of muscle relaxation and ventilation support, and obviously intra-abdominal pressure monitoring, but without surgery, and you stage and you start reducing the silo by day or every other day until you make a full reduction. with no surgery until when you think the patient is ready to go to the OR. And then usually you can do just one surgery and achieve what is called an anatomical closure. And let me explain exactly what I'm talking about. So this is the 3.2 kilo patient that was born with a giant omphalocele. And this is the duoderm that we cut in a T shape. Then that T shape is fixed, the part of the long part of the T around the skin on the abdominal wall, in the surrounding the defect, and the other part of the T wrap the omphalocele from each side. And we do exactly the same on the other side. So basically, you do two hemicircumference with the duoderm, and you wrap them together like a big hug. And you attach the duoderm also to the side of the abdominal wall to get a firm attachment to that. And then you put some more duoderms to support or secure that amniotic sac, sorry, the duoderm sac. And this transverse, this is a wooden tongue depressor. It's a very basic instrument, basically. And basically you stabilize the silo because it's very big and that can, go left and right. And this is not to support or do traction, just to support that stay in the center. And that's the first maneuver, the first day. Okay. So with that, you achieve two things. You are covering the amniotic sac and protecting them, and you stabilize everything that is the problem with, worms and fluid, problems with the patients. That's the first day. Our protocol now, we manage this patient sedated and intubated, but with no paralysis. Okay, so basically the management of this patient are much easier at the NICU. So the next step is start reducing the silo. So every time we push this little, tongue depressor, or could be anything else, you start pushing everything downwards into the abdomen without disrupting the amniotic sac. So you can see these lines is day 1, this is day 2, this will be day 3, or every other day, depending how the patient is, managing the compression every day. Every time we reduce this, we paralyze the patient. We learn this, that it's impossible to achieve anything without paralyzing the patient. So we just paralyze the patient to reduce the silo each day or every other day. And actually, this is as a real patient, this is day 9. Okay. So in 9 days and 4 the reduction, we achieve coming from, as you remember, from this to this. And this is the same patient. And obviously the patient was intubated all those days and just paralyzed with every reduction. The next step of this management is called flattening the flat. So although the abdomen is almost flat enough, we keep a little bit further in. We do a little stamp of duoderm and we push it even further down. That makes us more room of the abdomen. So we stretch even more the abdomen to have more space when we think is going to do it ready to go to the OR. And the last, this third part of the step procedure is called inversion of amnion. So this is the last part of the step procedure. You can see this is just the remaining of the huge amniotic sac that we have. We have all the bowel and the kidney and the liver inside. But we need to know that these edges, because here is the fascia, we can put these together. So basically, we approach what is called the amniofascia edge within each other, like this, and then we secure it again with a duoderm. This is how we know that the patient will be ready to go to the OR and try to do a definitive anatomical closure. If this patient tolerates this maneuver, the next day or 2 days after, we can start planning the surgery. And actually, this patient did it. So this is the day that we decide to go. We go to the OR, we close the fascia in anatomical. So this patient have a completely anatomical closure. So we put the fascia of the abdomen together, these the rectum muscles from each side, and then we close the skin. So from day one of life to get this, reduction of the silo, inversion of amnios, and the closure. So this is what we're doing in mainly of cases. There's some cases that or the defect is too big, or their cardiac condition. Some of them are obviously, are born with cardiac malformations, doesn't tolerate very well, and you can take longer time to achieve this. But in 95% of the patient, we have achieved this within the 15 days after being born. This is our 25 years review of managing these patients from 1994 to 2023. We can add here about 6 more patients, but the number was 55. The average weight was 2.7 grams, that's kilos. The average gestational age was 37 weeks. 40% of them presented associated morbidity. That's a really important thing in the outcomes. And 2 patients required suture of the rupture of the sac. So even the patient was born with a rupture of the amniotic sac, we were able to repair it and, put the silo on top of this. Usually the silo was staged, reduced every 24 to 48 hours, as I said, depending on how the patient responds to these reductions. The silo is always changed every 4 days because you need traction, and usually the silo gets wet, and with that, lose traction. So usually we change it every 4 days unless it's needed previously. 2 patients had local infections of the silo. I mean, the skin around the silo that was managed with antibiotics with no problems. And 3 patients had episode of high intra-abdominal pressure that require obviously loosening the compression back to the first day or the previous day. And we stop that, wait 48 hours, and start doing that again. As a whole, 97.5% of the patients achieve a primary closure, and 92% of them achieve an anatomical closure. 90% of them had an average time to closure of 14 days. As I said, 90% as an average within 15 days, from 7 to 38 days. 1 patient tolerated reduction, but not the closure, so we put a mesh on that patient. And actually I can say now is 2 because we had the second patient was here. She had a huge malformation associated with an agenesia of part of the abdominal wall that was impossible. Although we put everything inside the abdomen, was impossible to close the fascia. So we put a mesh to close the abdomen and then close the skin on top of that. And 2 patients, and now I can say 3, required a non-absorbable mesh to achieve the closure. There was no mortality related to this technique at all. 4 patients died due to associated malformation, mainly cardiac malformation. And we have been following this patient up to 16 months. So we know that these patients are doing very well with this approach so far. The conclusion of this presentation that this management first is effective and safe. It's very easy to perform. Everybody can do this everywhere in the world. That's why we like it. You don't need any technology. We just need this dressing that is basically all over around the world, and it's not that expensive. Usually requires only 1 surgery, and we know that it's a reduced morbidity and definitely no mortality related to this stage closure. And basically has the most excellent cosmetic result because basically there's only 1 surgery involved. We published this in a couple of years ago, if you want to see that, in 2020. This is the first series of our patients. I think I will stop there.